Welcome back to Equality, Diversity, Inclusion, Health Psychology podcast. This time I'm joined by Professor Shivani Sharma, and we are going to be exploring this particular conversation in how do we embed it in health psychology. We talked a lot about different types of conceptual ideas, but we want to really go into the conversation. Well, how do we embed it in? So, welcome Shivani to the podcast. How are you?
I'm good, thank you. And thank you for having me. And nice to see you after so many years. I think your listeners might not be aware, but I actually supervised your undergraduate project, wasn't it?
Yes, you did. And I remember thinking at the time, I'm like, I wonder where the future was going to go in terms of like, am I on the right path? I saw you like working closely on some really innovative projects at University of Hertfordshire. That's where you were my supervisor for my final year project. And I remember thinking, like, what would happen in the future, and the fact that we're having this conversation now, and we reconnected a while ago. I did think to myself, like, yeah, I wonder what that conversation would be like. So, no, thank you so much for taking the time, and thank you so much for being my supervisor at the time. And now I'm in that place now. It's weird, very weird. But yeah, I don't know if you wanted to give a bit more introduction about yourself, what you do, the kind of work you're up to, just for our audience to get an idea of the fantastic speaker we've got on our podcast today.
Yeah, well, thank you so much for your kind words and for having me again. So I'm Shivani. I am currently a Professor of Equity and Inclusion and Deputy Pro-Vice Chancellor in the College of Business and Social Sciences at Aston University, where I've only recently joined. I say recently, January earlier this year. My background is really in psychology. I, as most psychology students, started my journey as an undergraduate student. At the end of my studies, I was offered a PhD studentship, which I quite honestly admit now, given the kind of circumstances and family history of education from which I entered my undergraduate degree, I wasn't really sure what a PhD is and why I might like to do one. But I was really, really lucky to encounter some professors who wanted to support and nurture perhaps what I couldn't see at the moment, but they saw as talent towards research. So they encouraged me to take up the PhD and to choose an area that was meaningful to me at the time. And I had spent my undergraduate days, as many of us do, with cost of living considerations, etc., working on home programs for neurodiverse children. So that was an area that I was already really passionate about, and I pursued a PhD working with parents and children to develop a family-based intervention that can help parents make the most of their interactions with their children, given the range of demands and pulls and pressures that they experience in that parenting context from the system as well as their home environment. So I did my PhD, and at the end I was fortunate again to land myself in my first lectureship on the health psychology MSc that had been launched there at the time. So I taught on the MSc programme as well as managing an innovative university-wide personal development programme that we were also rolling out at the same time for students across the university. So that was really my first quick jump into academia as a career stage, and I just found myself very, very quickly being pulled into, I would say, middle to senior level management in a kind of school or college structure, faculty level. Essentially, different universities have different kind of titles for their internal structures, but I had roles such as deputy head of psychology, eventually head of psychology, then Associate Dean for the School of Life and Medical Sciences in Education. Various restructures later, again, psychology expanded to become a Department of Psychology, Sport and Geography, which I was, before I left, the head of, and the university's first executive lead for an academic area for equality, diversity, inclusion. And I think pursuing all those management experiences alongside undertaking my own research alongside that, which has been a challenge to sustain both from such an early stage. But I've always been really passionate about health, well-being, and it's naturally just through interactions that I've had taken me in different directions. So moving from work with neurodiverse children and families to now even doing work in kidney disease, I would say my overall research is really focused on protected attributes, social determinants of health in the health services more generally. So that then brought me as a combination of EDI leadership to the kind of role that I now have at Aston University, which is very much about people, performance, planning, culture. So the kind of things that I'm involved in are equality charter marks, for example, everything in relation to staff development and promotion, progression, retention, etc. So essentially, equity, inclusion is a golden thread that goes throughout all of my management and leadership practice, as well as something that has been a core part of my research trajectory from the beginning too. So that's me and a walkthrough from my life so far.
Yeah, I mean, I think that's been like a journey, hasn't it? And journey of like different experiences and skills. And I'm sure you've seen lots of healthy things and unhealthy things along the way. I mean, the first thought that came to mind was equality, diversity, inclusion. A sort of a thing when we, when you were my supervisor at that time. So this is going back in late 2009, 10-ish. Or is it more of a recent thing from your opinion? Like, has it always been there, or is it more of a thing, there's more emphasis now from what you found?
Yeah, I mean, I think there's always been an understanding that social justice is important. There's a long history to this that predates any of us, and lots of historical campaigning, etc., for rights, etc. However, I think individuals' relationship to the theme of equality, diversity, inclusion is shaped by their own history. So myself, for example, I'm considered to be probably a widening access student, first generation, low household income, etc. And my childhood experience was of having inequality in my school years, etc., bullying and all. And I also experienced some of that in the early stages of my career, partly more likely age related than anything else. However, I didn't have the right lens and framework to put over that. It's only when my work naturally pulled me into asking certain kinds of questions, and that I then connected with the idea of colonialism, etc. So had my family background been different, I may have had a different positionality in relation to that. But I definitely think that recent social events, the momentum around normalising equality, diversity, inclusion has definitely picked up. COVID has been a catalyst for that. The Black Lives Matter movement's been a catalyst for that. Various politicians at the moment, dare I say it, are also a catalyst for us thinking differently. And what's been nice to see, I think, definitely, is that there's a shift in research communities and students, etc., towards what they want to see from social justice, etc., too. So, yeah, I don't think it's a new thing, to come back to your words and question, but I think it's being more normalised and more easily accessible to people, that what does this actually mean? Because I personally even find the language of colonialism, decolonising curriculums in higher education and all quite exclusionary in some way, because it assumes that you have a certain baseline knowledge, which not all students, not all people in society do have, although they may have experienced injustice or have an awareness for it. You don't necessarily always have that academic language to put around it. So I think it's really important to be as simple as everyday terms with the things that we are referring to, the issues that we're trying to find solutions for.
And do you think, like, how does the future look? Do you think that will continue on that path? Like, we're going to keep making changes, or it's going to pause? As we said, you mentioned that the recent politicians and politics around this conversation. Or do you think we're just going to keep on going with it, and carry on with the momentum of EDI?
I'd like to think that some of the strategic decisions that are being made by particular organisations who have a place in government, who have a place, from setting various different kinds of policy contexts that affect the research, that influences all our lives, etc. There are some really positive strides being made. So I would say, quietly optimistic for the future, because I do think that I certainly am seeing more genuine engagement. So, for example, at the earliest parts of my career, when I was really trying to think about research inclusion, inclusive cultures, I would always feel like in meetings I'm that broken record that keeps saying, oh, well, what about people who can't speak English? What about people who need a disability adjustment? Or have we thought about what if, we put this survey online, but someone hasn't got a device or the skills to engage with it? How are we addressing these issues? And eventually I would give up, because I'd deal with the argument of, oh, this is just too hard for us to do, or we don't have the money, etc. Whereas, although I haven't changed in what I'm saying, I may have advanced and become more intersectional in my lens, for sure. But actually, rather than me being a bolt-on now, it's often people are asking right up front, okay, so how do we be inclusive from the outset in our thinking about this research, or in our thinking about this process, etc. So I've been on promotions panels or awards panels, etc. Not necessarily the universities, but outside, and people are upfront asking me about how do you think we can embed this? And okay, so that conversation is had before. Are you aware that people of certain demographics might sell themselves differently in an application, or alike? So I'm definitely more confident because of those changes that I've seen in a genuine, not tick boxy way.
Yeah, the reason why I'm very interested in this, and I'm sure our listeners will be asking the same question, like what's the relation between healthcare? Because I think education and healthcare, we have similar challenges. I don't know what your opinion is around access to education and access to healthcare, and the diversity in healthcare, and making sure there's equity in both. Are they the same, education and healthcare, in your opinion, or are they slightly different?
I think injustice and inequity in society is a systems problem. It's not owned by any one particular agent within that. It's a whole society issue. So it's going to take change across these different systems, both all collaborating together, but also contributing in the way that they can. So, for example, by the time somebody arrives in a university, they've got quite a long academic career already behind them, and we are not accountable when someone comes to me for things that may have happened before that. Similarly, clinicians often say to me, well, Shivani, I've got patient X with me, this is the clinical problem we have, I can't solve their housing, I can't solve their employment, etc. I can only do what I'm doing in the sphere of the disease management that I have been given as a responsibility. But we can, in that sphere, still make sure that we don't perpetuate what has come before. So certainly in education, for example, we have to think about what is a genuine requirement when we're setting our entry criteria, or if we decide to lower our entry criteria, then what support are we putting in to make sure that students actually can thrive? Because personally, as an academic, I love working with great talent too, but there is also a separate joy of taking somebody from place X to place Y, rather than just retaining a student who, entered in a really good position and just leaves without that much value added. For me, I get much joy out of adding value. So I think the support mechanisms, etc., that we put, and actually finding different ways to let people's knowledge, their experience, their curiosity show up in the classroom as well. So certainly we found that over the COVID pandemic, in the university where I was at the time, that changing assessments to coursework and alike, and actually really thinking about how we embed EDI considerations into the way we're asking questions, actually helped more students to succeed, because they were able to draw on their cultural backgrounds or their lived experience more to help direct their reading, their learning, etc., and the way that they then framed that. And it was really nice to see that when I left, many of the programs, MSc clinical psychology, etc., had retained that. Okay, we're going to ask a question about, how does the experience of autistic mothers of neurodiverse children vary across cultures, or just encouraging people then to bring in their life experience to help, and also for those opportunities to think about education that is not only Eurocentric but values truly worldviews. Because I think by doing that, we're trying to create a generation of psychologists that have this diversity intelligence that they then take into their everyday practice. Because it's not about saying your lens can be absolutely broad to cover everything, but it's about recognizing that you only know what you know, and there is value in gaining multiple perspectives in all of the work that you do, and actively encouraging difference into your settings, rather than just having an echo chamber around yourself, so that you can meaningfully impact change for a wider group of people. So certainly that's what I think we can do in education. And similarly, on the healthcare system side, I think there's been much more momentum towards true partnership, collaboration with communities who are affected by access inequalities, outcome inequalities. It's only yesterday I was speaking to an organisation through my role with the Birmingham and Solihull ICB, a community organisation that was doing amazing stuff around, access to dental care, access to advice, not to replace a GP, but GPs working, volunteering in the community to help those who had language or cultural barriers, or other inclusion barriers, to understand what their medication has been prescribed for and why they should adhere to that rather than take it ad hoc or alike. So that's placing services right in the heart of the community. So I think the system itself is also trying to reshape and re-engineer to work better with underserved communities, if I put it that way.
Yeah, no, thank you so much. I think there is a synergy between what you're saying around societal inequalities, societal problems. Do you think that health inequality, that the data that we get from health inequalities, helps us to understand the healthcare space a bit more better about the gaps, and has that been a key driver to addressing inclusion, diversity, and trying to improve equality?
Yeah, I mean, withstanding issues that there might be with data availability, obviously health care and health research as an area in terms of its access to linked data sets, big data sets, is absolutely, it's a field that's rapidly always evolving, and that data is necessary to help us not just use these big broad brush, okay, well, all minority ethnic communities need help with issue X, because actually even a cluster of a community like South Asians, there's lots of subgroups within that, and there's absolutely differences within those communities. So we know that when it comes to health and health outcomes, that Bangladeshi and Pakistani communities in England are particularly disadvantaged. So it's only through that granular data that we can get to understand where we need to perhaps equity weight our practices, so which communities need a more amount of resource investment to give them the best opportunity to live and age well.
And what should we consider when we embed? How do we embed it in terms of our healthcare? Like, what should we really consider as learners, as students, as practitioners, as policymakers? What do we really? How do we embed it in your opinion?
So I think for students, hopefully the thinking will have been done for you by your academics, because I know that certainly the professional body, etc., really, at least for those of us studying in England, is very keen on looking at EDI issues and how that comes to life in the curriculum. But I would encourage you also, if, for whatever reason, whenever you're thinking about directing your own learning, is to try and get broad perspectives, try and get broad views, don't just look for, I mean, I'm not saying that there's no quality indicators in research, etc., but try and look for research that comes from other countries, etc., too, and different range of types of journals, etc., so that you do get a broad view of the different perspectives that there are on the issues that you are studying. I think make effort. There are so many equality frameworks out there now for when you're planning your research, etc., that can help you think about how you talk about the research, the way you go about being transparent in the decisions you made and why. So I'll often get researchers, for example, who say to me, I'd really love to do some form of protected attributes adaptation in my research, but the funder's budget just won't allow it. So sometimes that might mean we design a smaller study within their large study, but other times I have had to be honest and say, well, okay, given that the funder themselves hadn't embedded EDI so much at that point, that okay, we say we acknowledge that it's an issue right up front, this is what it would take to solve it, or this is the plan without. So if you're making decisions that impact whether or not someone can be included or excluded, make sure that you're making them for absolutely the right reasons. So those inclusion criteria aren't just, you know, only access in English, only access if you don't only have one health condition, when lots of people are now living with multiple long-term conditions, etc. Just be really mindful when you're designing research who that research will engage and benefit. And then from the practitioner's side in healthcare and policymakers, I think, again, we need to be right up front thinking about where does inclusion and equity feature in our strategies, our policies, and to bring that to life. And it's not a let's think about it at the end thing. I think we need to do that health equity impact assessment right from the beginning, so that at each point of your decision making processes you have a good understanding of what the outcome might be, because what we don't want to end up with is resource investment from a human perspective, a financial perspective, and then a well-intended decision has a problematic outcome. So to give an example, you might develop a digital intervention, you might have lots of co-creation at the beginning and know that the content of the intervention is great, and then you roll it out and uptake is shockingly poor. Well, could it be because the people who you're trying to reach with your intervention or to engage to adopt your intervention don't have devices, or perhaps they don't have the skills that they need to use the technology? So although the intervention itself might be fine, no one's done that mapping perhaps of, well, how is the end user going to access this, etc. So if you did that as part of your assessment and inclusion plan right from the beginning, you'd end up with a better solution. So in a nutshell, I think everybody just needs to put this front and centre and as a golden thread throughout their work, almost a parallel running work stream rather than a bolt-on or an afterthought.
No, thank you so much. I think it's really been useful, that answer, really clear. And for our listeners, if you're listening, you can hear the different types of ways you can get involved, from trying to get that broader view, looking at frameworks, and also, at the end, what you said around how do you make decisions, make sure that someone's with you all along the way, not just start. Then you have, I don't know if you want to add any more thoughts on that, because I want to ask about your book chapter that's coming out.
Yeah, no. So I suppose for me, from all of that learning by doing, so it's not a case of I myself identify as a British Indian woman. It's not that because I have protected attributes of that description that I know everything about inclusion. I too invest in learning about the things that I don't know about. And over the years, all of these tools and strategies have been developed over time. And through that reflection, what's been nice is that the opportunity to contribute a chapter on health inequalities to the forthcoming SAGE handbook of health psychology came up, and I've been able to therefore really think about, if I was a student on an undergraduate degree, where would I want to start with this? recognizing that we all have a different relationship to the history of equality, diversity, inclusion. So really the book chapter aims to give people a fundamental background to what do we mean by the social determinants of health, which is literally, as the WHO, World Health Organization, states, it's the conditions in which people are born, live and age. And that shapes powerfully our health outcomes. So trying to give people a fundamental introduction to that contextual backdrop. As far as possible, recognizing that language is constantly evolving, talking about what do people mean when they say equity, inclusion, equality, diversity, because this language is often used interchangeably, but actually sometimes shouldn't be because it is referring to something specific. So it aims to try to give that contextual background, understand the language, and you will need to be able to navigate if you're thinking about EDI in your health education or interventions that you design. Then to talk about kind of how we know that there's evidence for these social inequalities, both within and between countries, sharing examples of interventions that have worked. But then the bit that I enjoyed, I suppose, most was saying, and what do we do about this moving forward? So research inclusion, etc., is also something that I think I've been able to bring in that is novel in terms of what I want to say to students who will be the main users, I suppose, of the textbook. So yeah, I think hopefully it will be well received. As I said, it's a bit of an eclectic mix of my thinking on the subject, but I've really tried to put myself back in the position of a student. And sometimes I think when you read really theoretically heavy content, it can almost feel like a minefield for a student. I myself can remember feeling like that a bit reading about epistemology in qualitative research. I really had to read and reread as an undergraduate. So with that in mind, I kind of have taken it, really tried to strip it back to everybody it's easy to engage with, even if you don't have a psychology background and you're just interested in a basic insight into health inequalities.
And when is the book chapter coming out?
Oh, that is a good question. I'd like to say I think next year. I'm pretty sure there's an email in my inbox about it, which I haven't had a chance to read yet because I was running to the podcast.
Oh, no problem. I was going to say, like, yeah, for audiences, listeners in the future, if you're thinking what day is this, it's the year 2024. So
yeah, 2025, I think it will be out.
No problem. And if anyone wants to reach out to you, what's the best way to contact yourself, like how to connect if they want to learn more?
I've accidentally became a big user of LinkedIn. So you can normally read about my thoughts on various different topics on LinkedIn, and I do often get direct messages on there, but the best place to reach me is if you just Google me on the university's website. My email address, etc., is there.
No, thank you so much, and I'll share your details in the bio with the audience. So what would you like for our listeners to take away from this podcast and the conversation in your experience? So everything that you learned, what do you want them to really consider when they're considering equality, diversity and inclusion in health psychology practice or teaching and research?
Yeah, I mean, throughout the podcast, I tried to give a little bit of an insight into my career and the way research in particular and leadership has shaped out. And I think some of the core themes that come out of that, I would say to anybody listening, be curious, be patient, and be bold. Curious because I think you should know about things that are outside of our everyday sphere and comfort zone. Patient because some of the challenges, issues you're trying to find solutions to are so entrenched and systemic that just one project or is not going to solve the issue. So you might try, you might succeed, you might try, you might be knocked back a bit, but keep going because consistency and time will build trust in the communities that you are trying to benefit. And then being bold, i.e. that you want to do something different as opposed to perpetuate the norm. So curious, patient, bold. Keep it with you.
Thank you, Shivani, so much for taking part in the podcast. And I'm sure There's going to be lots of people going to be wanting to ask questions and got so many thoughts. And I'm sure, we might interview again in the future to see how people may have, for example, received that book chapter and what you think about it and how it's been incorporated. So thank you again so much for your time. I will leave your details with the in the bio for people to stay in touch or get to know more. But thank you again.
Great, thank you so much for having me, and good to see you after so long.
Yes, definitely. I'm sure we'll be in touch.